Shall I start, sir?
Sir, 1 second, if you don't mind. ठीक है. Okay, yes, sir. We'll start, sir.
Good morning, everyone. Myself, Arvind, and I will be speaking on our invention, that is a smartphone annotation tool for image labeling for artificial intelligence in diabetic retinopathy. So as we all know that deep learning and artificial intelligence have become widespread because of the availability of digital data, and supervised learning algorithms have shown human level performance. To get huge data set with good quality control, there is a need of an annotation tool with a customizable feature set. So this multi-centric study evaluated the viability of having an in-house annotation tool which work on a smartphone and can be used in a healthcare setting. Supervised learning algorithms like the convolutional neural network have human level or better performance in radiology, ophthalmology, and in automated vehicles, but requires huge amount of labeled or annotated data and high variance if the grader is an expert or a fresher. So there are various annotation tools available like the label box, supervisedly, and labeling desktop-based graphic user interface. They have many disadvantages like not being mobile, progress of graders can't be supervised, loss of data due to hardware issue, no data exchange for offline mode, and loss of annotations due to poor network. So in India, 75 million people are affected, so they require better screening for early prevention and risk evaluation, especially in the remotest of the area. So the objective of this tool were to quantify the amount of damage already done, segmentation of lesions, and at present IDX-DR by M. Abramov is the only US FDA approved AI-based equipment. So we followed the ICDR severity disease scale to grade diabetic retinopathy, and a binary module based on CNN deep learning algorithm was developed for referable retinal disease and non-referable retinal disease. So it begins with the efforts of 32 retinal specialists and 8 IIT engineers. It started with an online tool, Label Box, for labeling of publicly available data sets to evaluate the need of a custom tool. It has many advantages, like we were able to grade multiple retinal images easily in a short span of time, user-friendly tool using user interface and user feedback. It was integrated with advanced testing and internal validation sets. It was faster and mobile. Progress tracking was available, and domain expert feedback for graphic user interface was also there. It has many special features like the zoom capacity of 3 options, green channel for red-free image, and brightness and contrast slider to make the ungradable images gradable, and a smarter image compression format that is WebP, so it maintains resolution of images but keeping low memory footprints. So it's a small video. So we invented our own in-house image annotation tool as seen in the video. Adding in annotations for an image is pretty easy. View the image, magnify it, change the brightness, change the contrast as needed, click on the relevant option, choose the extra details, and the annotation is saved. The analytics on the landing page shows the pending and completed images, and the graph shows the maximum number of images stacked by the other users in real time and gave the daily target settings. These imaging data sets are generally in the range of thousands and can be overwhelming for a single person. So we chunk them into sets, each containing 1,000 images or less, which a grader can complete in 2 weeks. The issues mentioned earlier were resolved as follows. For faster image loading, we resized images into smaller sized thumbnails with a smaller memory footprint and still maintaining the visual quality. We leveraged the asynchronous capabilities of the browser and didn't load just 1 but 3 images preemptively so that the grader doesn't need to wait for the next image to load. The initial interface was basic and evolved based on the grader feedback. It is now designed on a decision tree structure to render the nested subclassification and, of course, extra options. So we have seen a total behavioral change where on the online tools the grader used to work only on the weekend, but on our tool we have a logged users on all the days of the week. Also the average time taken to label a single image reduced substantially. We validated the AI algorithm developed using annotations on this tool on some new testing data sets and found them to have a really high performance scores. This strengthens our hypothesis that this tool is no different than the desktop-based tools and with added benefits of being portable, flexible, and also can be used in the offline mode. So we wish to introduce more gamification, label optimization to be used in telemedicine. So the user feedback and feature usage stats after evaluating over 2 lakhs of retinal images confirm our hypothesis with high sensitivity of 89%. Now we are able to develop an offline smartphone app which can diagnose patients of common retinal disease in less than 1 minute, 53 seconds to be exact, and very soon it will be available on Google Play Store. And this app will have a definite role in telemedicine and bridging gap between man and machine. And this application will surely transform patient management in near future. Thank you. Thank you so very much for your patient listening.
Thank you, Dr. Arvind, for a wonderful paper. You said this is going to be a kind of a bridging kind of a thing which can be associated with telemedicine as well. What is the hypothesis for this? How do you want to place this?
It is this application is available very soon. It's in the patent process, so it will be available on the Android smartphone app. So if any image is loaded, so it will go multi-level screening on the base of algorithm that we have developed after screening and grading over 2 lakh of retinal images.
Okay.
So it will give a referable whether the referral is required or not required.
Yes, so whole idea of screening is that is only the referral versus non-referral.
Yeah.
Now, what you have also modified a little bit on the image acquisition protocol in the sense where
Yeah.
the gradable, non-gradable images.
Yeah.
Most of the softwares, they don't do that actually.
Yeah, we have incorporated that.
That's a great tool. But again, how much, how successful you are making a non-gradable image a gradable one?
Sir, there were 20% of images that were non-gradable. So 15% we were able to grade by using the zoom function, by using the brightness and contrast slider, and this red-free image. So we were able to grade 15%, 5% out of 2 lakh images we were not able to grade.
Any other questions?
So this is on your machine, your software.
Yeah.
I mean, presuming that the aim of this is to become a universal applicability.
Yes, sir. We are here to replace IDXDR very soon.
Then what happens to images which are non-gradable from other machines, other sources?
Sir, there are 2 grader will be expert, 1 will be a fresher, and if they are unable to grade that image, it will come back to us for the grading.
Okay, it would go back to.
Yeah.
Thank you so much, sir.
Thank you, sir.
I think we'll move on next to Dr. Ramesh Venkatesh. He's got a simultaneous presentation in another hall. Then next.
Shall I start?
Yes, please. Please start.
Yeah, good morning everyone. The topic for my free paper presentation today is contribute factors for developing foveal neovascularization in proliferative diabetic retinopathy. I'm Dr. Ramesh Venkatesh and I have no financial interest. The hallmark for diagnosis of PDR is the identification of an NVE or NVD or both. Now, foveal NVE in PDR cases is a very rare finding, and the reason why the fovea is usually spared is because it's an avascular structure. It does not have any retinal capillaries and is primarily supplied by the choriocapillaries. In proliferative diabetic retinopathy, the choroidal flow and the volume reduces, the choroidal perfusion reduces, and therefore it becomes a theoretical possibility for a new vessel formation to occur at the fovea. There is existing literature which talks about foveal neovascularization in proliferative diabetic retinopathy, but what this literature lacks is that there is no information which talks about the contributory factors to the development of foveal NV. And hence we decided to plan this study, where the aim of the study was to analyze a series of cases of foveal neovascularization in proliferative diabetic retinopathy and ascertain the factors which lead to its development. Coming to the methodology, it's a retrospective case control study where the cases are patients with PDR with foveal neovascularization and no diabetic maculopathy, and control cases of PDR with no foveal NV and no diabetic maculopathy studied between Jan 2020 and December 2020. So basically, we diagnosed PDR on the basis of angiography and then looked at the presence of neovascularization within 1 millimeter ETDRS circle at the fovea. If they were present, then we included them as cases, and if they were absent, we included them as controls, and then did the OCT and OCT angiography in these patients. Coming to the OCT measurements, we looked at the OCT measurements were done on the Heidelberg Spectralis machine, where we looked at the total retinal thickness, the inner retinal layer thickness, the outer retinal layer thicknesses, the RP layer thickness, and the subfoveal choroidal thickness, all of which were obtained by the automated tool available on the Spectralis software. The OCT angiography was done on the Avanti OptoView machine, where you measured the FAZ area on the 3 millimeter and the 6 millimeter scans, the vessel density in the superficial capillary plexus and in the deep capillary plexus at the 1 millimeter grid, and the total 3 millimeter and the 6 millimeter areas. Coming to the results, so we had a total of 124 eyes diagnosed angiographically with proliferative diabetic retinopathy, and 12 eyes of 10 patients with foveal neovascularization, and a similar number of cases were taken as the controls. The prevalence of foveal NV in our study was around 10%, and coming to the comparison between the cases and the controls, most of them were comparable except for the presence of type 2 macular telangiectasia, which was associated with foveal neovascularization in PDR cases. So type 2 MACTEL was seen in eyes with PDR and foveal neovascularization. Coming to the OCT findings, the retinal thickness between the cases and the controls were all comparable, but what was important and interesting was the thinner choroid, which we had in the cases group compared to the controls group. Even when you look at the OCT angiography findings, we found that the foveal avascular area had enlarged in the 3 millimeter and the 6 millimeter scan, both in the superficial and the deep capillary plexus slabs, and the vessel density had increased, the vessel density had reduced, sorry, in the case group. So in eyes with foveal NV, we can say that the choroid was thinner at the fovea, the FAZ area had enlarged, and the vessel density at the fovea was reduced. Now coming to the univariate and the multivariate logistic regression analysis, we identified that it is the foveal avascular zone in the 3 millimeter by 3 millimeter superficial capillary plexus slab which contributes primarily to the development of the foveal neovascularization. So increase in the FAZ area in the 3 millimeter by 3 millimeter scab, primarily in the superficial capillary plexus, it leads to the development of foveal NV in PDR eyes. The strengths of our study were the largest series of cases of foveal neovascularization in PDR cases to be reported in literature. We had a control group. We analyzed for the different OCT and OCT angiography parameters, and this study also explains the possible etiopathogenesis for the development of foveal neovascularization in PDR eyes. But there are some limitations as well, and the limitations being the small number of cases. But to get a higher number of cases, we needed to screen more cases of proliferative diabetic retinopathy. We did not have follow-up data to look into what happened to the foveal neovascularization. We could not comment on the prognostic differences between the two groups, whether these foveal neovascularizations eventually bled and led to a premacular bleed. And we did not look into the treatment outcomes with anti-VEGF, PRP, or both. So to conclude, foveal neovascularization in PDR is an uncommon finding with a prevalence of 10%, and when it occurs, there is reduced perfusion of the choroid and the inner retinal layers. Thank you very much.
Thank you, Ramesh. Nice paper. Couple of questions. Now, when you say you excluded MACTEL, so what are the diagnostic criteria of exclusion of MACTEL, and how do you identify with foveal NV?
So we did not exclude MACTEL. We in fact found MACTEL in 5 patients of PDR cases having foveal NV. So we did not exclude MACTEL. The confusion was whether we have foveal neovascularization or epiretinal neovascularization, which is being described in MACTEL eyes as well. So now you are confused whether this foveal neovascularization is secondary to MACTEL, or is it because of the PDR disease itself? So the OCT tells us the answer in the sense that the choroid, when it is thin, and the inner retina when it is affected, and you have a larger FAZ area on the octa, it tells that that is what is primarily leading to the foveal neovascularization, and therefore the MACTEL was not responsible for the development of the neovascularization.
Cases, how many neovascular fronts were nasal and how many were temporal?
So most of them we found it on the temporal aspect of the temporal margin of the FAZ itself. Yeah, but we had 2 cases where we had it on the nasal aspect as well.
They were not extensions of the.
They were not extensions. They were totally independent.
Any difference in choroidal thickness in patient who had MACTEL versus foveal NV?
in patients who had MACTEL versus foveal NV in PDR cases.
Yeah.
So the choroidal thickness in the MACTEL group was not affected.
Not affected.
Not affected.
And nor did they have, they may not have had clear-cut features of MACTEL, but abnormalities in the middle retinal layers or like
Yeah,
how you-
so when we look at the staging of MACTEL itself, sir, you develop the neovascularization only when the pigment plaques and the stage 4 disease develops.
I'm talking about your
PDR.
foveal,
Yeah, so we did not have any of those features. We did not have any of those features, yes.
because with thinning, as you're mentioning, so there was only choroidal thinning, no retinal thinning.
No retinal. Yeah, but the FAZ area on the octa and the inner retinal areas, means the vessel densities, they were affected on the OCT angiography.
The management approach changed when you are treating these
Yes,
cases,
yes,
though you
yes.
have not probably evaluated.
We have not evaluated, but when it comes to the clinic, when the minute we have a foveal neovascularization, we usually tend to go more towards an anti-VEGF, combining it with an anti-VEGF therapy, rather than when you have no foveal neovascularization, we treat them with pan-retinal photocoagulation. Yeah, thank you very much.
Thank you, Ramesh. I think next we'll call Shruti Vaishali.
Okay, so can you start?
What's your good name?
Good morning to one and all gathered here. So my paper is on annotating and predicting the AI toolbox for diagnosing diabetic retinopathy from confocal fundus images. No financial interest. Even though AI has revolutionized the field of medicine, its incorporation in our daily clinical practice is not as expected because of the black box dilemma. This is basically because the rationale behind the predictions of AI is not clearly understood, and hence the mild hesitation. So our purpose is to overcome this black box dilemma. So we utilized a novel convolutional neural network approach and utilized true color confocal images. Instead of just diagnosing the grade of retinopathy, we made sure we are able to diagnose the different clinical signs and the intricate details like hard exudates, microaneurysms, NVEs, laser spots in each cases. And this concept has never been reported in literature before. So our data set consisted of 8,000 high-quality fundus images, and overall we utilized 114 ophthalmic signs, a lot of comorbid conditions also included, and the annotation was done using Microsoft Visual Object Tagging Tool, VOTT, and this is online free available tagging tool. And once the fundus images were captured, the annotation tool was used and a human annotator annotated them. And the data set was then processed by Sandston AI toolbox, and the prediction was done. And then finally, again, a human validation was done, and again, retraining was done. So this was a human in the loop annotation. And finally, we were able to get the correct predicted image. So this is the process of annotation that we used. So you can see that a customized annotator for the disc, for normal disc and even for the NVDs, and then for the normal macula, for normal vessels and overall normal fundus. And similarly for the pathologies involved, from every small detail of microaneurysms, hard exudates, even if there are n number of them, everything were annotated separately, so that we were able to predict the outcomes properly. And even cases with the macular edema, each and every microaneurysms, dot plot hemorrhages, hard exudates, and finally overall annotation of CSME was done. So again, you can see the cotton wool spot, the NVE, the laser spots, and the final annotation looked somewhat like this. So even sometimes 10 minutes can take up to each image. So custom, you only look once version 5 was based, and we used that to locate and draw customized anchor boxes over the fundus images. And a batch of 8 was used to train the fundus images for class probabilities, objectness scores, and bounding boxes. So of the 8,000 images, 60% was used for training, 20% for validation, and 20% untrained images were used for the final testing. And the descriptive statistics for these 1,400 held out test images were finally calculated. So this table shows the prevalence of different grades of diabetic retinopathy amongst our study groups, of which you can see the mild and moderate by the most number. And this table shows the age of onset, the gender, the type of diabetes, and duration of diabetes amongst different groups of the training data, the validation, and the held out test data. So finally, we used the mean average precision for calculating the results. So it was calculated by for all the classes and overall intersection over union threshold. So IOU was basically calculated by dividing the area of overlap over the area of union, of which we had annotated initially. So of the 114 annotation, you can see some of the annotations were done more number of times than the others based on the clinical data. Similarly, which is shown in our 3D map. And finally, you can see the bounding boxes sizes. The small sizes were actually more in number than the larger bounding boxes. So from we split the data into 3 tests of 400, 600, and 400 images. And you can see from the start, it was initially the correct predictions was 79.5%, which gradually increased to 91% as we were increasing the number of test images. And even the wrong predictions and the missed findings were decreasing over time. So the sensitivity of the final test was 81.6% with a specificity of 100%. And the IOU was gradually increasing over from test 1 to test 2. Similarly, the objectness loss, which is basically the objects marked wrongly by the AI, and the classification loss was decreasing for the test 3. And the precision, the recall, and the mean average precision of from 0.5 to 0.9 was increasing over to test 3. So this is the final image which was annotated and given to us, predicted for mild, moderate, severe, and PDR. So you can see all the clinical findings were found out by the software. So we are trying to build an explainable AI model with a good sensitivity and specificity, and utilizing true color fundus photograph for training actually improves the interpretability. So even minute details will not be missed. So conclusion is that with constant training via feedback mechanism, we can overcome the black box dilemma. And but sometimes with the low resolution fundus cameras, it is difficult to get the predicted value. And better to go for even more multimodal clinical imaging, as we can build a more reliable AI model. Thank you. These are my references.
Thank you, Shruti. Nice presentation.
Thank you, sir.
Do you think, though you have showed good sensitivity and specificity, but it is slightly low as compared to the published literature?
Definitely, sir, but it's a pilot study and it's still in the training model. So we keep constantly retesting it, as I was saying, with the feedback mechanism, so that in which area the missed findings or the particular region, the sensitivity is low, we are trying to work on it, sir, to bring out a better, more sensitive model.
Yeah, and the other question comes to mind is, how do you define like the scale, like the missed areas?
Okay, yes.
So how are you comparing it with other skip areas?
Skip areas. So basically, we have one retina specialist, one glaucoma specialist with us, who are finally doing the testing, sir. So they are both blinded for each other's findings. So they finally give us the from the predicted data. They sit and give us which are the areas that are missed and which are the areas that are correctly predicted. So they are our final judges for the.
So ultimately, it's observer based.
It's observer based, sir.
Anything else?
For diabetic macular edema,
Yes, sir.
for edema, what you have taken?
We clinically, based on the images, we are taking the microaneurysms and the hard exudates, sir. But based on that, we definitely need a prediction which says this patient further needs OCT macular edema to find out if it's a clinically significant macular edema, sir.
So thickness is not taken.
Not taken. As of now, no multimodal imaging, sir.
Do you need to incorporate to actually find out whether how useful it could be in usual practice?
So based on the data that we have collected is 8,000. I feel even the more we train, the more the AI model learns, because based on the distribution of data, it was seen that the severe and PDR cases were actually less. Even the the prevalence was also less. So we are training them comparatively less than the other mild and moderate cases. So that is where we sometimes tend to miss some findings, and they are the important ones. So we have to balance our model accordingly, sir. So those cases will need to be trained more. So the numbers exactly doesn't matter. But, yes,
I'll just rephrase this question.
Sure,
that has there been either by you
Yes, sir.
or somebody else working out
Yes, sir.
of what's the minimum number of
Minimum.
cases required, so that the
We can-
whichever AI machine or deep learning thing you want to train,
Yes, sir.
that is an adequate number, like in our clinical studies you work out, na,
Yes, sir. Yes, sir. So the exact number has not been worked out, sir. But then the problem is because there is something big data and small data, but the big data is only available with companies like Google or Yahoo and the other giants. But we all have only small data. So it would be better if we can actually collaborate and everyone can provide some images, and that will work out in a big way. So that's the blockchain technology that we are working on next. Yeah.
Absolutely.
Thank you, sir.
The last question for
Yes,
you
sir.
is the future of multimodal imaging is 3D imaging.
Yes, sir.
Yeah.
Definitely. Yes, sir.
So how do you foresee that these things can be put it in 3D technology as well?
See, that is definitely possible, sir, because that's, as I was saying in the conclusion, multimodal imaging is mandatory because we have to be more precise on our diagnosis and our outcomes, sir.
Okay. Any other questions? Thank you, Shruti.
Thank you, sir.
I think Dr. Anupama is there. Dr. Piyush Kohli. Dr. Rahul Prasad. Can you present on behalf of Dr. Manish Nadar?
कौन सा number है?
This is 478. Can you call and check these people whether they are coming or not? These three absentees.
Good morning, everyone.
That's what. Yeah, please start.
My name is Manoj Shettigar. I am presenting on behalf of Dr. Manisha Nanda. She is professor and unit head of Retina in Regional Institute of Ophthalmology, PJMS, Rohtak. The topic of presentation is role of retinal specialist and smartphone fundus photography in ROCM. Introduction. In the mucormycosis, in the post-COVID era, in the post-COVID-19 recovery patients, there was a sudden surge of rhino-orbital cerebral mucormycosis cases nationwide due to immunologically and metabolically compromised status. The second most fungal infection was Aspergillus. It is an invasive fungal infection that usually occurs in the immunocompromised patients and sometimes presents as an orbital apex syndrome initially. It is rapidly fatal without an early diagnosis and treatment. Aims and objectives: to describe the retinal manifestation and role of retinal specialist and smartphone fundus photography in post-COVID-19 ROCM patients in a multi-speciality tertiary care hospital in North India. Material and methods: an analytical observation cross-sectional study was done out in the for initial 20 to 24 patients admitted in the mucormycosis in the Tertiary Care Center, Institute of North India. A detailed history examination was done. The fundus images were captured using the 2.2 pan-retinal and 20D lens based on smartphone fundus photography. And contrast enhanced MRI and orbit and paranasal sinus were done in every patient to see the extent and spread for the planning for the further management. Out of the 224 patients, 176 patients had history of COVID-19 infection in the past. 134 patients had history of hospital stay during COVID-19. 98 patients had oxygen supplementation. 76 had steroid intake. Only 12 patients had taken vaccine against the COVID-19 and none of them were fully vaccinated. The most common age group was between 40 to 60. The most common predisposing factors were diabetes mellitus, and there were 121 patients out, and there were 69 patients were newly diagnosed diabetes mellitus patients. In the major group was in the visual acuity from 624 to 636, and there were PL negative group was from 35, and total number of exentrations were done on 16 patients. Out of 224 patients of mucormycosis, only 60 patients had retinal manifestations. fundus findings will not only help in the staging but also in the visual acuity potential of the eye. Therefore, the detailed fundus examination by the retinal specialist must be carried out in every patient. The retinal findings in the ROCM include CRAO happens due to the secondary infiltration or the direct infiltration of the central retinal artery by angioinvasion of fungal infection from in the orbit. It can be combined CRAO and CRVO, disc pallor, optic atrophy, pre-existing diabetic retinopathy. CRAO was the most common retinal manifestation in the patients with orbital mucormycosis. In the study by staging proposed by Dr. Honavar et al., the stage 3, that is stage 3C, central retinal artery comes under stage 3. Also CRAO, CRVO, superior orbital fissure involvement. This is a case 1, 53-year-old male with history of COVID-19 infection 20 days back, presented with the right eye PL positive and PR accurate, pupil with the fixed mid-dilated. There was complete ophthalmoplegia. The smartphone fundus photography done using 2.2 panretinal lens. The examination showed diffuse retinal whitening with cherry red spots suggestive of CRAO. MRI showed the right eye proptosis with ill-defined steer hyperintense with fat stranding in intracorneal and extracorneal compartment. And 5 doses of retrobulbar amphotericin injection was given with IV liposomal amphotericin B. This is the second case. Patient presented with the history of drooping the left eyelid and loss of vision since 2 days. On examination, patient had hand movement and PR accurate with complete ophthalmoplegia. There was ptosis and mild proptosis was present. And left eye showed with the 2.2 panretinal lens, there was a diffuse retinal whitening with cherry red spot with perfused macula, suggestive of CRAO with patent cilioretinal artery occlusion. This is the third case, 42-year-old male, history of Covaxin. First dose was given to this patient and patient was diagnosed with de novo diabetes mellitus. Patient had uncontrolled diabetes. This is a red-free photograph with showing CRAO with cherry red spot. And this patient also had tenting on MRI. And this patient was planned for bilateral FES with the left eye exenteration. This is the fourth case, patient 72-year-old female with the PL negative in the both eyes. The right eye fundus imaging showed CRAO, left eye showed combined vascular occlusion with cherry red spot. For the investigation were done KOH mount, culture and histopathological examination. This is the fifth case, the 47-year-old female with the 10 years of diabetes history, presented with complete ophthalmoplegia and fixed dilated pupil. The left eye showed complete disc pallor. This is the sixth case. In the sixth case, this imaging media was not clear. It was done in 20 diopter lens. Peripapillary retinal whitening was seen with the disc edema with multiple peripheral fungal colonies, suggestive of mucormycosis. This is the seventh case. The patient presented with extensive facial necrosis and black SR formation in the left face. Patient was advised FES with exenteration and maxillectomy. So the discussion, the pre-existing diseases such as diabetes mellitus, previous history of respiratory pathology, history of immunosuppression, oxygen supplementation, iron overload can predispose to rhino-orbital mucormycosis. So early symptoms include early unilateral nasal stuffiness, facial numbness, retroorbital pain, headache, fever. The role of a retinal specialist is we can document the orbital inflammation, muscle involvement, optic nerve involvement, optic sheath, orbital apex, cavernous sinus, and intracranial extent involvement. But the CMRI can't tell the CRAO, CRVO, combined vascular occlusion, disc pallor, and optic atrophy. So we strongly emphasize the fundus examination of every ROCM patient. It not only helps in the categorizing ROCM but also helps in the visual potential of the affected eye. The patient with CRAO and combined vascular occlusion should be considered for exenteration on urgent basis so that the intracranial spread can be prevented and the patient life can be saved. The role of smartphone fundus photography is that despite the availability of fundus camera in our institute, we have to rely on bedside smartphone photography because of the sick, immobile patient, and patient were in other wards like ENT medicine or maxillofacial surgery wards. So most of them were immobile, so that and the transportation was difficult and cumbersome. The handy tool was this handy tool was with the short learning curve, not for not only diagnosing but also documenting the fundus findings, but also monitoring the progression. The patients of ROCM have complete ophthalmoplegia. It's not feasible for them to focus on the target of fundus photography machine. So the smart fundus photography gives an extra edge to document the fundus findings by moving in different direction and focusing the different quadrants. So even though the ROCM has risen from the ashes and affected COVID-19 survivors dramatically by increasing the morbidity and mortality, early diagnosis and timely intervention with multidisciplinary approach is key to its management. To conclude, CMRI with the orbit is an important tool in diagnosing and monitoring of ROCM, but it cannot provide information regarding CRAO, CRVO. So fundus examination of every ROCM patient should be emphasized and should be done with the retina specialist, as it not only helps in categorizing ROCM but
Time is
also
up already.
okay. Smartphone fundus photography can be a handy tool, and with the short learning curve, it will help in the documenting retinal findings. Thank you.
Thanks. Nicely documented cases. The questions from the panel?
Which smartphone fundus photography tool did you use? Sir, we used a cell phone and 20 diopter.
On your own, you
yes,
were able to
with
focus
that.
and do
Yeah,
it?
we focused.
So the same person was doing all the photographs, or?
There were two a person like residents were involved in this.
Okay, very well done job.
Sorry, shall I ask?
Yeah, please.
Means I have been doing it for quite some time, this fundus photography. Not that easy as it looks, and you need to have a good phone at the same time.
Yes, sir.
You know, and I believe there is not a short learning curve. It has a long learning curve for a very good photograph, though you have documented very nicely. Good to see all these photographs. But what sir was asking, I particularly want to ask, which software did you use for this? Because you need a constant flashlight for the photograph, isn't it?
Yes, sir. We actually turned on the video.
And the flashlight. And no, every smartphone does not have that function that you have simultaneous video and the flashlight.
Like basic MI.
No, but what I use is a candy cam. So what sir was basically asking, which software did you use for this? I believe sir was asking this.
Sir, regular video apps in the smartphone, sir. Like any other special apps were not used.
Okay, but my smartphone does not have, maybe it's inferior quality, maybe. It does not.
iPhone generally captures the best one compared to any other that we have observed.
Yeah, these were all iPhone photographs.
Just a side question.
Yes,
Did
sir.
you analyze how many of these patients were taking oxygen therapy at home and how many were from the hospital?
Yes, sir. That
Sorry,
was
I missed that.
Yeah, it was included. Wait.
Can you do verbal answering? You can go back now.
Yeah, you can. We can go on to the next one. You can tell me afterwards.
Yeah,
Thank
sure.
you.
Okay. Thank you, sir.
Yeah, but nicely documented cases. So it highlights the importance of documentation as well as thorough examination of these patients, which is very important, and most often or not has been missed quite extensively in the practices around. Thank you once again, and we move on to Dr. Pradeep Sagar.
Good morning, one and all. I am Dr. Pradeep. I will be presenting my paper on targeted laser photocoagulation of capillary aneurysms with TRIM in diabetic macular edema. The microaneurysms are the earliest clinical findings of diabetic retinopathy, and the leaky microaneurysms contribute to DME. Aneurysms which are slightly larger than the typical microaneurysms are described in DME, and they are described as telangiectatic capillaries, capillary microaneurysms, and so on. It has been documented that they are better identified on ICG and infrared imaging. In this presentation, we will be discussing about the capillary aneurysms with a rim on color fundus photograph. Here we can see that there is an aneurysm with a rim around it. It is confirmed on OCT by the presence of a hyporeflective lumen and a hyperreflective rim. In a retrospective study, we noted that DME due to capillary aneurysms with rim responded poorly to anti-VEGF. The purpose of the study is to assess the efficacy of the targeted laser photocoagulation in management of DME secondary to these capillary aneurysms with rim. We included eyes with DME with associated presence of capillary aneurysms with rim within the macula. We included both treatment naive eyes and eyes which responded poorly to intravitreal agents. The focal laser setting used was 532 nanometer double frequency Nd:YAG laser was used from Iridex. The spot size was 50 to 100 micron based on the size of the aneurysm, and the endpoint was complete blanching of aneurysm. We identified these aneurysms on color fundus photograph, and we confirmed them on optical coherence tomography. The patients were followed every 4 weeks until the resolution of edema, and once the edema resolved, we followed them every 3 months. 10 eyes were included in the study. So I will be discussing each case. This is the case 1. This was treated earlier with bevacizumab with poor response to treatment. Here we can see that there is a capillary aneurysm with a white rim. 2 months after laser photocoagulation, we can see that there is shrinkage in the size and it's more white now. In OCT, we can see that there was a complete obliteration of the lumen of this aneurysm, as we can see the presence of a homogeneous hyperreflectivity, and there was a complete resolution of macular edema by 2 months, and there was no recurrence till the last follow-up at 6 months. Moving on to case number 2, the patient was initially treated with multiple injections of bevacizumab and dexamethasone implant with no response. Here we can see that there is a large aneurysm with a white rim. 2 months after laser photocoagulation, we can see that this cavity is completely replaced by a homogeneous hyperreflectivity suggestive of obliteration, and there was a complete restoration of foveal contour. And there was no recurrence of macular edema till a last follow-up, which was 24 months. Based on the encouraging results in the other eye, the fellow eye of this patient was treated with focal laser. We can see that there is a complete obliteration of aneurysm and a complete resolution of macular edema 3 months after laser photocoagulation. And we can see that he had a recurrence after 18 months due to a development of a new capillary aneurysm with a rim. Moving on to case 4, here we can see that there is an aneurysm with a white rim and macular edema. 2 months after laser photocoagulation, the aneurysm was barely visible. In this patient, it was considered as a primary therapy based on the encouraging results from the previous cases. OCT shows a complete obliteration of the lumen with normalization of foveal contour. There was no recurrence till 6 months follow-up. Case number 5, laser was considered as a primary therapy. We can see at 1 month there is a complete obliteration of the aneurysm, which is confirmed on OCT, and there is a complete resolution of macular edema at 1 month, and there was no recurrence till 4 months follow-up. Case number 6, 2 months after laser, there is a complete obliteration of the lumen. There is near normal resolution of macular edema with near normal foveal contour. There was a recurrence at 12 months, and he was switched to anti-VEGF. Case number 7, there is a complete obliteration of aneurysm, but the SRF is resolved, but the IRF is still persistent. Case number 8, we can see that there is one aneurysm shows obliteration, but the other aneurysm is not yet obliterated. There is a resolution of NSD, but the IRF is persistent. So case number 9, there is a complete obliteration of aneurysm, but no response in reduction in macular edema. Case number 10, there is a complete, we can see that post laser there was an intraretinal hemorrhage surrounding the aneurysm. There was obliteration of the lumen, as we can see on OCT, but the edema was persistent and shifted to an intravitreal therapy. So out of the 10 eyes, With center involving DME, 6 eyes showed a complete resolution, 2 eyes showed a partial resolution, and no improvement in 2 eyes. Visual improvement was noted in all the 6 eyes with complete resolution. 9 eyes showed complete occlusion of aneurysm by 3-month follow-up. The limitations of the study are it's a retrospective study, small sample size, variable follow-up duration, long-term risk secondary to laser were not assessed, and the confounding factors such as systemic status is not considered. To summarize, the capillary aneurysms with RIM are seen in DME. It may be associated with poor response to intravitreal pharmacotherapy. It can be better identified on color photograph and confirmed by OCT in contrast to the previously described ICG or infrared imaging. Targeted laser photocoagulation results in good response in at least half of the cases. So a prompt identification of these aneurysms should be made during clinical examination and can be confirmed on OCT, and it helps in a better management of DME and decreases the treatment burden. Thank you.
Thank you. Nice presentation. Two things. One is good importance of showing that focal laser still has a role, which
Thank
most of us have forgotten, to use in clinical practice at least. But the question comes here is, you said you have not done a systemic evaluation for this patient thoroughly. So any specific reason for this?
Systemic evaluation has been done, sir, but since it's a retrospective study, we are not very sure about whether all the patients had a definite like systemic control. There are few patients who had a poor systemic control also.
So which is the most important systemic factor you are looking here?
So control of systemic control of glycemic control would be something which we are considering, and in patients with NSD, even hypertension plays a very important role. If the control of hypertension itself may lead to resolution.
Yes, so
NSD.
associated factors have to be included in that, including lipid profile and as well as anemic state. Any questions from the panel?
So, were all these patients non-responsive to anti-VEGF, only those were taken? Or if you saw these macroaneurysms, you treated them with laser primarily?
The 4 eyes were non-responders, the initial 4 cases. Based on the good response from those cases, we considered primary therapy in the rest of the cases.
Okay.
And among them, except for 2 cases, most of the cases showed a good response. In those, we waited for maximum of 2 months, and still at 2 months, if there was persistence of edema or there is no reduction at all, we shifted to intravitreal therapy.
Okay. And was there any limit how close you would come to the fovea? Or
out of the 10 eyes, in 9 eyes, we have lasered away from the fovea, sir. Like it's almost beyond around 1000 micron from fovea, except for 1 case in which it was treated with almost multiple injections, almost like 6 to 7 anti-VEGFs and 3 to 4 dexamethasone implant. In that particular case, it was quite close to fovea, almost at around 800 micron from the center. But since these are larger, the chances of laser hitting the adjacent area is less likely. If you use a smaller laser spot like 50 micron, and we have measured the size of the aneurysm, all of them were more than 150 micron, so we could exactly precisely point on it, and we could laser so that the collateral damage is quite minimal.
I just want to clear things. Like, did you laser only those aneurysms, or you lasered other aneurysms which were not ring enhancing?
Only this, nothing. Only these aneurysms.
Maybe you may have used only 1 shot or maybe 2 shots in
Yes,
such
sir,
cases.
Yes, sir.
There was one case, 8, I think. So you said that it was, there were 2 aneurysms in the papillomacular bundle. 1 shut down, 1 didn't shut down. So what did you do with that?
So we
Did you
advised a repeat
you
laser.
said you retreated?
Yes, sir. We advised repeat laser, but he was lost follow-ups.
Okay. Now, in the papillomacular bundle, is there any modulation of parameters or anything else you're doing, or
Sir,
you just achieve blanching?
The one which I showed, actually, it was temporal, sir. It was not in the papillomacular.
No. I'm okay.
Of all the cases, one patient, the case number 4, in that actually there were 2 aneurysms. One was at the papillomacular bundle, one was inferior to it. We treated only the one which was inferior, and it resulted in resolution of the edema at the fovea, but adjacent to the papillomacular bundle near the other aneurysm, it is still persistent.
And will it make more sense to do a red-free imaging and then laser these patients?
Yes, sir. Theoretically, yeah, definitely, red-free imaging should have a role. We could have looked into it also, sir.
Okay, thank you. I think we'll move on to Dr. Yash is there. Yes, Yash.
Thank you, sir.
Thank you.
Good morning, everyone. I am Dr. Yash Verma. I'll be presenting a paper on proliferative diabetic retinopathy detection, a comparison between clinical examination, optomap imaging, and fundus fluorescein angiography. In today's day and age, wide field fundus imaging is being increasingly used for the diagnosis and screening, as well as staging of diabetic retinopathy. And clinical examination has always been used. So for diagnosing proliferative diabetic retinopathy, that is PDR, it is important to look for NVE or NVDs. It can be done with clinical examination or retinal imaging. Retinal imaging can be a 7-field fundus photo, ultra-wide field imaging, which gives us 200 degrees view of the fundus, and dilated fundus fluorescein angiography. There have been many studies where they've showed us sensitivity and specificity of optomap imaging or optos, the wide field imaging, even for 7 photos field imaging. And they've compared it either with clinical examination or either with the amongst themselves, like Claris and Optos, both are wide field imaging. None of these studies have compared it with the gold standard, that is fundus fluorescein angiography. So this is one case which was seen by one of our senior consultant, and it was diagnosed as a severe NPDR, but he had a little doubt of it being being some severe NPDR with CNP areas, and FFA was done, and we found that there were neovascularization. So the diagnosis changed to the proliferative diabetic retinopathy. So this is another case where a diagnosis of PDR was made, and on fundus fluorescein angiography, we saw that there were just microaneurysms which were leaking and there were CNP areas, so the diagnosis changed to the severe NPDR. So in case 1, there was an underdiagnosis of PDR which could have led to severe vision loss if the patient wouldn't have followed up and if FFA would not have been done. In the case 2, there was overdiagnosis, and if we would have gone with the clinical examination itself, we would have overtreated with laser or intravitreal injection with associated problems. So the question is simple yet pertinent. Does optos or wide field imaging have a role in the definitive diagnosis of PDR? So we looked into 3 modalities. We did retinal imaging, optos imaging, retinal examination by a senior consultant, optos imaging which was graded by a senior consultant, and FFA. And the findings of retinal examination and wide field fundus imaging was compared with fundus fluorescein angiography for the detection of proliferative diabetic retinopathy. It was a prospective study over a period of 3 years. All the patients with suspected PDR and diabetic maculopathy were included. So clinical examination was done. When on examination there was a doubt of it being a suspected PDR or no PDR with a diabetic macular edema, we advised FFA for this patient. FFA was not done on the same day. The patient was called upon the other day. Undilated wide field imaging fundus photography was done, and after that FFA was done. So all the readers at the fundus examination, the optos imaging, and FFA, the reading was done by senior consultant with more than 5 years of experience. This is an example of optos image which was provided to the senior consultants to grade the diabetic retinopathy. So when on ultra-wide field imaging, they diagnosed it as PDR or no PDR, and then it was compared with the gold standard, that is FFA. And when the diagnosis of PDR matched, the true positivity increases, hence the sensitivity increases. And when the diagnosis of no PDR matched, the true negativity increases, that is the specificity increased. But whenever there was a misdiagnosis, the sensitivity and specificity went down. Similarly, ultra-wide field imaging was compared with clinical examination, and sensitivity and specificity analysis was done. So a total of 980 eyes of 496 patients were included. Most of them were right eye, most of the patients were male. And this is a bar graph showing that clinical examination and this orange one, which is ultra-wide field imaging, did an overdiagnosis of severe NPDR while they underdiagnosed patients with PDR. The sensitivity of retinal examination, clinical examination, was 63%, while the specificity was 88%, while that of optos imaging was 43% and specificity was 76%. When we compared optos imaging with clinical examination, the sensitivity and specificity was lower. So our study suggests that wide field imaging and retinal examination has higher rate of missing NVs as compared to FFA for the diagnosis of PDR. There are a few studies where they've looked at the sensitivity and specificity of wide field imaging, and they found it to be around 73 to 96%. The sensitivity to at 73, specificity at 96, which is higher than our study, which is probably because they've compared it with clinical examination, and we compared it with the gold standard fundus fluorescein angiography. They provided 3 steering images to the reader. We provided 1 single exported JPEG file to the reader. So the strength of our study is that we have a large data. A senior consultant with high level of expertise did the DR grading. The weaknesses is that we just looked into severe NPDR and PDR patients. The mild and moderate were not looked into. Cases with severe and definite diagnosis of PDR like a VH or a TRD were not taken into account, and a dilated optomap imaging was not done. So in conclusion, both clinical examination and undilated optomap imaging is inferior to the fundus fluorescein angiography in detection of PDR, which hence remains the gold standard, giving scope for the wider application. Thank you.
Medical examination included only indirect ophthalmoscopy
Indirect
with the
ophthalmoscopy.
binocular indirect ophthalmoscope?
Yes, indirect ophthalmoscopy.
Were different lenses used or just
No,
the
sir.
standard 20D?
Standard 20D.
That's the reason why the sensitivity and this thing was low. Normally for diabetic retinopathy or in general fundus exam, for the benefit of so many of our younger colleagues who are in the audience, it's always good to examine the fundus on the slit lamp.
Yes.
Slit lamp indirect ophthalmoscopy as well as indirect ophthalmoscopy with the binocular. And if you want to, because of speed and faster screening, at least use a 15D lens. So then your picking up of lesions will be much higher. And the objective of all this is so that we reduce the number of invasive testings.
Yes.
Thank you.
I think nicely summarized. A couple of questions. The fundus fluorescein angiography was wide field or standard?
So this was a standard one. We don't have a wide field angiography, so that is a drawback here.
Yes. So do you feel that will aid to diagnosis, even further? The sensitivity, specificity
Yes.
will increase further?
Yes, sir. But anyway, we are saying that FFA, even with not wide field, is giving us, it's like the gold standard. We are not missing out.
Yes, gold standard is there, but we are,
That will make it
we
better.
are, moving on kind of a DRCR protocol. So that is one. A point well taken on missing out of lesions, but as sir rightly said, clinical examination is still the key. And also, what is the future you see with this technology, whatever you have mentioned?
Sir, so the future is, today we saw a lot of talk about artificial intelligence, annotating, and some of the colleagues said that mild moderate is more important, that they focused more on it. But I would say that is not more important. More important is this gray area of severe NPDR to PDR, where we might miss some cases. So when treatment comes into picture. So when it is crucial, it is the FFA which will do the diagnosis.
Anything you want to add, sir?
Nothing specific, but I think there could be bias in interpreting the color photographs.
Okay, thank you. We move on to Dr. John.
Which one?
John? John Davis? John Davis, Secretary.
Thank you, sir. So I'm going to be presenting on this paper on how to build your own artificial intelligence software for free to diagnose retinal fundus photographs. So mind you, the problem statement which we try to solve here is to differentiate between different retinal diseases, which is an easier solution than grading diabetic retinopathy. But this is just a proof of concept. We have no financial interest in this presentation. We use free software to make that. Firstly, ophthalmology has a lot of imaging and measurable big data, which is ideal for application of artificial intelligence. And AI has been used for detection of diabetic retinopathy, glaucoma, ARMD, retinopathy of prematurity, retinal vascular occlusions, other retinal diseases, in addition to keratoconus, measuring, calculating IOL power, and several other parts of ophthalmology. And AI is considered complex, expensive, and out of reach for most people. So we propose to create an AI algorithm using free online tools. So it was to develop an AI algorithm that can detect retinal diseases from fundus photographs and evaluate. We used the software Teachable Machine by Google, and we did it as an observational study. We had a less number, that is 58 fundus photographs of ARMD, BRAO, CRVO, macular hole, retinitis pigmentosa, subhyaloid hemorrhage from data. And this was almost equal in number. One image from each category was randomly set aside for testing. And this teachable machine software was trained using the remaining 52 images. We tried with an epoch of 50, that is how long the training goes on for, and also 500. This was completed quickly, but then accuracy was not sufficient. After increasing the number of epochs to 5,000, and it took 5 hours for the software to process and develop the algorithm, we did this testing. The testing images were used, and the ones with 50 and 500 epochs did show some sensitivity, but it was very less, 20 to 40% confidence in detecting the disease. So we trained with 500 epochs, and it showed a recognition in confidence of 80 to 95% for identifying the disease. So the teachable machine platform is a very low cost, effective method for creating an artificial intelligence algorithm. This image shows some of the test data. These are all subhyaloid hemorrhages, and this is the testing images. So these are the images we use for checking the algorithm. This is the teachable machine interface. We group the images into various categories. If you see here, there are 9 images in all the categories. BRAO, CRVO, macular hole, retinitis pigmentosa, subhyaloid hemorrhage. We adjust the settings here and train the model. And once the model is trained, it allows us to test it. And the most common use of AI in ophthalmology is fundus images to detect diabetic retinopathy, and the FDA has approved IDX-DR for this purpose, for detecting referable DR. And typically it requires more computer processing power, so it is uploaded online to a server, which is not always possible in places like India, and in large-scale screening in rural areas where it is most needed. There was a study which showed an offline AI by Medios AI, which is on the Remedio Fundus on phone from Bangalore, which showed a high sensitivity and specificity for using this. Teachable machine allowed the creation of a simple AI at actually zero cost. So this is again the interface, and this is the preview window. Here we load an image, and then it detects what of these diseases it is. It was able to detect this image as a CRVO with 100% accuracy. This model can be exported to a website on Google servers, or you can export it onto a Raspberry Pi or any other computer of your own, and then it can use image upload to detect the disease and tell you. So the limitations of our study is a small number of images. We use only 58 images for both training and testing. But and also there is a resolution limitation with the free teachable machine. And it is also not capable of highlighting hotspots to show what part of the image resulted in the diagnosis. So that is the black box problem of AI. These are my references. Thank you.
So what are the alternative softwares? Are there any other better
Absolutely, sir.
softwares?
So if you want to use a commercial AI, in fact, the Medio's AI is pretty good. It is on the Remedio funders on phone cameras, no commercial interest. There is a free version which can be accessed through the Orbis International's website. Just go to cybersite.orbis.org. If you register as an ophthalmologist, you can upload your own fundus photographs to the site. It will run it through their AI. And
what I meant was for creation of your own.
For creation of AI, you can, if you know programming, you can actually use Google TensorFlow and actually code the whole thing. This is a very basic interface where you can just give the images and let the algorithm decide what are the differences. If you want to code it yourself, you will have to know a little more advanced AI concepts, which is you have to do programming basically.
So would you just tested out 58 images, right?
Yes, sir.
So if suppose it was say 5,800 images or 20,000, would the things
I suppose
change?
the
And
accuracy would increase much more even with this software. This
it will
software
accept so many large numbers eventually.
it has some limit, but I think it is 1,000 or so.
Okay.
So I've used 58 because that is the only number of images which I could easily get. If we had a larger database, we could definitely go up to 1,000 per set, I believe.
And is there any issue with data privacy in the sense,
So-
you may have amongst those 58, you could have had some VIP.
So these are all anonymized data. There is no patient information at all. So there was no privacy issues with this data.
Thank you.
Thank you, sir.
Thank you, John. We move on to Dr. Prithvi. Yeah.
Good morning, everybody. I'll be talking about pediatric CNVM, the etiology and treatment outcomes with intravitreal anti-VEGF in our setting. No financial interest and conflict of interest. As we know, choroidal neovascularization is a visually debilitating disease in adults and children. But the most common cause in adults are ARMD, and it's varied in children. You can see there are infectious causes, pathological myopia, hereditary choroidal degeneration, ocular trauma, neoplasias, and idiopathic. And as we know that what need for treatment is, in adults there is a tremendous burden of visual acuity being reduced, but then the children have to live with it for a longer year, and longer blind years are there, and higher disability adjusted life years. So the treatment modalities for the past were laser photocoagulation, submacular surgeries, photodynamic therapy, transpupillary thermotherapy. But recently we have been using a lot of anti-VEGFs as treatment modalities. So our aim was to share demographic detail, etiology, pattern, and pattern of presentation, long-term outcomes of pediatric CNVM following anti-VEGF therapy. Methodology, it was a retrospective study of 26 eyes of 23 pediatric patients, less than 18 years, and it was a 10-year study. And the data abstraction were age, gender, laterality was taken, presenting complaints, etiology, visual acuity, and multimodal imaging. The data analysis were done by Microsoft Excel and statistics by GraphPad. The inclusion exclusion criteria, all the patients with the relevant data and all complete data were taken, incomplete data was excluded, and patient with follow-up of more than 6 months were taken into consideration. And previously treated with laser or anti-VEGF were excluded. Incomplete data was excluded. Any other ocular pathology, they were excluded. So visual acuity, fundus examination, FFA, ICG, SD, OCT, and when necessary and relevant, OCT-A was also taken. The regimen we followed was monthly pro-rata till CNVM regression was seen. By doing SD OCT were taken into consideration, and the monthly follow-up of patients were who are undergoing the anti-VEGF treatment were taken OCTs for to give the treatment regimen, and those cases with the additional uveitic features were given anti-inflammatory treatment too. The demographics features 26 eyes, 23 consecutive pediatric patients were taken, and in that mean follow-up was 8 to 72 months, and in females were more seen to have this CNV, and laterality was unilateral. In demographic features, you can see the mean age was 11.7 plus or minus 3.3, and the range was from 4 to 16 years. Right eye was of 54% and 46 of left eye. The main symptoms which were there were the diminution of vision. Squint was of only 12%. The demographic features of the cause etiology in our study was inflammatory or uveitic, which accounts to 62%. The second was idiopathic of 19%, followed by choroidal dystrophies 12 and traumatic in 8%. Out of the 62% inflammatory, the toxoplasma was the highest, followed by multifocal choroiditis, VKH, presumed TB, and posterior uveitis with the unspecific etiology. According to the location and types, the location we had the subfoveal the highest, followed by the peripapillary, and then the extrafoveal location. And the type 1 was around 17%, and type 2 was of 83% in our study. Functional and anatomical results, you could see that at presentation, the logmar visual acuity was 0.8, and which in the final visit was 0.4. So there was a gain of 0.4, that's 20 letters, and it was statistically significant. The same as central macular thickness was 405, and in the final visit after the injections were 249 with the same direction of 156 mean, and it was statistically significant, and there were nil complication of any of these anti-VEGFs. There was one CNV secondary to choroideremia had a recurrence after 6 months, for which we had to give another injection and regressed. The mean injection per eye in our study was 2 injections. As you can see, the regression patterns in VKH of and OCT-A showing the regression pattern as well. This is a case of penetrating trauma, which have seen regression after injections. This is a picture, OCT picture of best disease with regression photos, and as OCT-A photos. When literature review, and we have found that there are many studies done, but then all were single-centric, but they didn't have a lot of samples, and out of them, multicentric were major, and all of these had just 35 to 45 cases, but they were all multicentric. Our study was single-centric. In discussion, I would like to say the pediatric CNVs as associated with underlying ocular comorbidities, which comprises the retinochoroidal integrity, allows the development of new vessels. And spontaneous regression can occur due to preserved RP Brooks integrity, that is 20% of spontaneous regression was seen in our series. And anti-VEGF injection were the mainstay of treatment in pediatric CNV, and respond well to therapy with mean number of 2 injection in our. With the faster regression or lower recurrence risk.
Can you sum up faster? Time is up.
Adopting a PRN approach may be the best thing. And The limitation with this, it was a retrospective study, and the rarity of the disease is the major concern over here. So this was a single-centric study with the 28.1 mean, and anti-VEGF is safe in pediatric CNV and favorable prognosis with fewer anti-VEGFs were required and lower tendency of recurrence. Thank you.
Just one. Yeah, thank you. Just one question from the panel, please. Please go ahead, sir. Anything? I think well presented. Due to lack of time, we'll skip the question session for you. Dr. Anupama, can you come, please? We had 4 more talks. Dr. Piyush Kohli is there? Yeah, you'll be the next. Please stick to the time, Anupama.
Yes, sure, sir. Very good morning to all of you. Today I'm here with my study on clinical correlation of conjunctival vessel width with the grades of retinopathy in diabetes mellitus. As we all know, how to move? As we all know, diabetes is a chronic progressive metabolic disorder with various microvascular and macrovascular complications. It has emerged as a leading cause of blindness. However, blindness due to diabetic retinopathy is highly preventable if early detection and timely intervention is initiated. The vascular complications related to diabetes do not present themselves until significant microvascular damages have already occurred. Diabetic retinopathy occurs due to microvascular hemodynamic disturbance, and similar changes in the conjunctival vessels are very well studied and documented. With all this background, the aim of my study was to measure the width of the conjunctival vessel and to correlate it with the severity of the grades of diabetic retinopathy. Our study is a hospital-based observational study done over a period between May 2020 to July 2021 at RIO RIMS Ranchi with due ethical approval taken from our institutional ethics committee. All the diagnosed patients of diabetes mellitus and those who gave consent for the study were included in our study, whereas those patients who had media opacity obscuring posterior segment examination and those who had any other ocular and systemic pathology and who didn't give consent for the study were excluded from the study. 300 eyes of 150 patients of diabetes mellitus of the age group 50 to 70 years were examined. After taking the general and ophthalmic history and assessment of best corrected visual acuity, complete ophthalmic examination was done. Anterior segment imaging for the measurement of most prominent temporal conjunctival vessel width using red-free filter and distal slit lamp biomicroscopy was done. Posterior segment examination for the grading of diabetic retinopathy was done using indirect ophthalmoscopy based on the ETDRS classification. All the findings were noted on MS Excel sheet and analyzed using SPSS 21.2. Continuous data was measured as mean plus minus standard deviation. Quantitative data was analyzed using paired t-test. The value of p less than or equal to 0.05 was considered as statistically significant. Coming to the results, there were no significant difference in the sex distribution. Majority of the patients were in the age group of 50 to 60 years with an average duration of diabetes of 8.8 plus minus 3.8 years as shown in the table below. Majority of patients had mild to moderate NPDR that constituted about 55.3% of the total study population. Severe non-proliferative diabetic retinopathy was seen in 21.3% of the study population, and 14% of the patients had features of proliferative diabetic retinopathy, whereas 9.3% had no features of diabetic retinopathy. This is the table showing the conjunctival vessel width with the severity of grades of the diabetic retinopathy. The average conjunctival vessel width that was taken from the most prominent temporal bulbar conjunctiva was 27.4 micron in diabetic who had no retinopathy, and that gradually increased as the severity of diabetes increased from 32.6 micron in mild to 36.8 micron in moderate, 40.2 in severe, and 43.9 in proliferative diabetic retinopathy. This is the diagrammatic representation of the previous table, which shows the correlation of conjunctival vessel width with the increasing severity of diabetic retinopathy. In discussion, a study conducted by Khan M.A. et al. On 96 diabetic patients showed the mean conjunctival vessel width of 40.61 micron, which uniformly increased from 34.4 micron in mild NPDR to 53.5 micron in the proliferative diabetic retinopathy group, which was statistically significant. And similar results were also observed by Rishi Sharma et al. In 280 eyes of 140 patients using slit lamp imaging system for conjunctival vessel width measurement. In a study, significant retinopathy was seen among those in the 6th and 7th decade, which corroborates with other published data. While it all showed a higher prevalence of diabetes and its complications in men as compared to women, which was not observed in our study, as we found equal preponderance among both males and females, as was observed by the study conducted by Khan M. et al. Cheung et al. Studied the conjunctival vessel morphology using computer-assisted intravital microscopy and concluded significant increase in the conjunctival vessel width among diabetes as compared to the non-diabetic controls. And similar results were also obtained by Langry et al. By conducting the study through conjunctival angioscopy. Our study findings resonates with many of the published studies and establishes a positive correlation of conjunctival vessel width with the increasing rates of severity of diabetic retinopathy. Hence, I conclude conjunctival vessel width positively correlates with the severity of diabetic retinopathy. Measurement of conjunctival vessel width has potential of being a marker for early detection of diabetic microangiopathy. Detecting the changes of diabetic retinopathy early and timely intervention to halt the disease progression can go a long way in the preventing the morbidity associated with it. These are all my references. Thank you.
Thank you. One good presentation.
Thank you.
I think we'll skip the question answer session for you because you're a non-ratified member. So sorry for that.
Okay.
We cannot mark that. We move on to Dr. Piyush.
Thank you, sir.
Thank you. Dr. Piyush Kohli.
Good morning, everyone. I'll be presenting our study on clinical features, management, and outcomes for patients with coexisting diabetes mellitus and CML. So, diabetic retinopathy is one of the leading causes of blindness among the working population. The risk factors for development and progression of diabetic retinopathy are poor metabolic control, age, diabetic duration, smoking, hypertension, dyslipidemia, chronic renal failure, and anemia. CML also leads to microangiopathy. Duke et al. First described the peripheral microaneurysms in trypsin digested retinal preparations. Out of these, 50% of the eyes had clinical leukemia. So diabetic retinopathy and CML retinopathy both leads to CNP areas. In diabetic retinopathy, it is because of the basement membrane thickening, pericyte loss, capillary endothelial cell dysfunction. Whereas retinal ischemia in CML is because of hyperviscosity, endothelial damage, and anemia. So aim of the study was to evaluate the clinical presentation, management strategies, and outcomes in patients with coexisting diabetes mellitus and CML. So this was a retrospective hospital-based study performed at Arvind Eye Hospital, Madurai. Records of all the patients from 2017 to 20 were analyzed. Treatment protocol: the proliferative retinopathy patients underwent PRP. Patients with macular edema underwent intravitreal injections. Those with NVI or NVA underwent PRP as well as intravitreal anti-VEGF injections. Non-resolving VH, which we took as 2 to 3 months, and or TRD, underwent 23-gauge vitrectomy with a tamponade, which could be either silicone oil, SF6, or air. Uncontrolled IOP in case of NVG underwent the glaucoma filtration surgery or cycloablation. The procedure was decided on the basis of severity of clinical signs and surgeon's discretion. So we evaluated 14 patients, 12 males, 5 females. Mean age was 49.4 years. Mean duration was 8.2 years for diabetes. Mean HbA1c was 6.9. with HbA1c more than 8 in only 3 patients. So bilateral visual loss was seen in 11 patients, that is 65% of the patients. 82% of the eyes presented with visual loss, and mean presenting visual acuity was logmar 0.9, that comes out to be 20 by 160. The range was from finger counting to 20 by 20. All the patients presented with proliferative retinopathy. The most common presenting features were vitreous hemorrhage, FPs, TRD, macular edema, NVG, and hyphema. So this is a patient with a 45-year-old male, HbA1c 6.2, which is quite less, which is quite controlled, known case of CML, and as we can see, there are a lot of NVs and CNP areas. Another patient, 58-year-old, HbA1c is again on the lower side, 6.6, known case of CML, presenting with PRH, FP, and MTRD. Another patient with HbA1c just 5.7 on the lower side, known case of CML, presenting with subhyaloid hemorrhage and TRD. Another patient, 44-year-old male, HbA1c 7.9, known case of CML, presenting with MTRD. Now this was a patient he was not a known case of CML, HbA1c 12.3 on the higher side. Initially there was steroid hyalosis and diagnosed as mild NPDR, but just a month later he presented with vitreous hemorrhage and slowly TRD began. FFA was not done in the first visit. So no prior history of CML was seen in 6 patients, that is about 35.3 patients. Reasons for suspicion of CML was anemia during the initial workup, fast progression of proliferative retinopathy despite adequate metabolic control, and non-responding CME despite adequate metabolic control and anti-VEGF injections. So treatment that was installed was PRP in 65% of the patients, anti-VEGF injections in 35%, and vitrectomy in 38%. Post-op tamponade was silicone oil in 10 eyes and air in 3 eyes. Surgery was avoided in 2 patients because of poor prognosis, and 1 patient did not consent for surgery. So mean follow-up was 14.5 months. Retina was attached in 31 eyes, that is except for the 3 eyes that were not operated. SOR was done in 8 of the 10 eyes, and there was no re-RD. So final BCVA was logMAR 0.72, that comes out to be 20 by 105 on Snellen's chart, range going from NPL to 20 by 20. So more than 20 by 60 was there in 50% of the eyes, whereas less than 20 by 200 was in 30% of the eyes. Average visual gain was 1.2 lines. About 17 eyes gained vision, whereas around 20% of the eyes lost vision. So what were the causes of loss of vision? There were development of progression of TRD, CME, as well as development of NVG. So eyes with NVG at presentation all underwent PRP and anti-VEGF injections. One also underwent 810 nanometer micropulse laser. 2 eyes developed NVG after vitrectomy and silicone oil injection, and both underwent 810 micropulse laser. All the patients had normalized IOP in the end. One case report which I'll present, another 38-year-old female, we presented with bilateral PDR and DME. BCVA was 20 by 40, diabetes for 5 years, and HbA1c was in the lower range, 5.4 years. PRP and multiple anti-VEGF injections were given, but the macular edema did not resolve. As we can see, despite 4 or 5 injections, macular edema has not resolved despite adequate metabolic control. Further workup was done, that is CBC, and that was suggestive of CML. So she was started on imatinib, and in response, 2 months later, she developed VH and NVG in 1 eye. So she underwent vitrectomy, silicone oil tamponade, and micropulse cycloablation. Final outcome after 33 months was 20 by 80 in 1 eye and 20 by 1200 in the vitrectomized eye, although retina was attached. So this was the patient. She developed vitreous hemorrhage after starting of imatinib and finally after the surgery. So many patients do not give the history of CML. We should suspect if there is anemia in the initial workup. So we suggest that CBC should be done in the initial presentation in all the patients. If the patient presents with NVG at presentation, obviously the other causes can be ocular ischemic syndrome. And if there is progression of proliferative retinopathy and non-responding CME despite adequate metabolic control. So retinopathy progresses rapidly despite treatment. 40% patients require vitrectomy. The acute endothelial insult during the active initiates a cascade which exacerbates the PDR even after CML resolution, and poor visual outcome is there despite adequate metabolic anatomical and few case reports will say that imatinib may exacerbate ocular disease. We also had a similar case, but still this deterioration can be because of the natural cause of course of the disease. So it is important to suspect CML, especially in advanced disease or fast progression despite adequate systemic causes. CBC should be done, aggressive ocular and systemic treatment should be done. They should be counseled for high risk visual loss and NVG. CML survival is improving, so we'll have a lot of patients who have coexisting diabetes and CML. Physicians should have an early ophthalmic clinical examination, and a multiple disciplinary approach is required. Thank you.
Thank you, Piyush. But this comes to the basic question again, Yes, even the, at initial presentation itself, before initiating the treatment, don't you think the systemic workup for all these patients is mandatory?
So we do, but sometimes HB is normal in these patients. TLC is raised, and we usually do not do a complete blood count in patients presenting with PDR.
No, but can you look at the other way around? Like even a complete blood count should be included because
Yes,
anemia and lipid profile and renal profile becomes a mandatory thing.
Yes, that's we suggest, sir. CBC should be done.
Yeah.
Yes.
And any significance of vitreous hemorrhage is slightly different in these patients as compared to normal vitreous hemorrhage in PDR,
So
what you get?
one is post-surgery, sir. Most of them tend to recur. So we always try to put silicone oil in these patients.
More than the recurrence, something else would also be there. Paritosh, sir, you want to ask? Okay, leave it. In interest of time, we'll skip those discussion. Thank you so much once again. Can we have Dr. Rahul Prasad? Yeah, come please.
Yeah.
Please stick to the time, Dr. Rahul.
Yes, sir. Very good morning, sir. Today I'll be presenting my work on foveal cystic spaces with hyperreflective wall as a biomarker of diabetic macular edema refractory to anti-VEGF therapy. No financial disclosures associated. Now, introduction. Diabetic macular edema is the most important cause of poor visual prognosis in diabetic patient. We know there is a breakdown of blood-retinal barrier which leads to accumulation of intracellular and extracellular fluids. Fundus fluorescent angiography and SDOCT evaluates different pattern of vascular hyperpermeability and the neuroglial impairment. Central subfield thickness assessment provides an objective and a quantitative diagnosis of central involving diabetic macular edema. Macular thickness includes cystoid macular edema, serous retinal detachment, sponge-like retinal swelling on OCT, and vitrometicular adhesion or traction. The pathogenesis of diabetic macular edema accounts for severe uncontrolled hyperglycemia, which leads to formation of advanced glycation end products, which leads to release of protein kinase C pathway reactivation, which does lead to loss of pericytes and altered vascular permeability. Then we also have the release of VEGF, which are potent cytokines which causes neoangiogenesis and alteration in the structure of tight junctions. That leads to blood-retinal barrier breakdown, plasma protein leakage into the sternum, high oncotic pressure, and interstitial edema. This anti-VEGF therapy forms the first-line treatment of diabetic macular edema. Now, the aim of our study was to establish hyperreflective wall of cystic spaces that are present in fovea would act as a biomarker of diabetic macular edema, which becomes refractory to bevacizumab injection. The study design was a cross-sectional study was done in about 50 patients having central involving diabetic macular edema visiting tertiary eye center from August 2019 to July 2021 who received multiple monthly injection of bevacizumab. Visual outcome and the DME remission were correlated with the SDOCT finding at follow-up visits till about 18 months. The inclusion criteria included central involving diabetic macular edema, presence of cystic spaces at the center of the fovea, adult having more than 20 years with diabetic mellitus, and visual impairment due to central involving diabetic macular edema. The exclusion criteria were any opacities in the media affecting the vision, chorioretinal diseases, any prior treatment of DME or macular pathologies, cataract surgery within the last 3 months, and any intraocular intervention other than cataract surgery in the last 2 months. The research and measurement were done with the principle of declaration of Helsinki after taking proper approval from the Institutional Ethics Committee. The best corrected visual acuity was assessed, and after detailed ophthalmic evaluation, central macular thickness was measured in the SDOCT images. Medium or large foveal cystic spaces, those were more than 250 micrometers horizontal width, as defined was taken in the center 1 millimeter of the retinal layer section were assessed. Smaller cystis were actually excluded. Reflectivity levels, thickness of the hyperreflective wall, presence of trail, and disruption of the EZ zone were also evaluated. Eyes without central involving diabetic macular edema from any time to the point 18 months were defined as cause of DME remission at that point of time as described previously. Absence of cystic abnormalities from any point to about the 18-month visit was defined as the remission of cystoid abnormalities similarly. Intervention was done in form of giving intravitreal bevacizumab injection. The result, the 5 out of the 50 cases had hyperreflective wall in the foveal cystic space on OCT evaluation at follow-up visit with no DME remission and poor visual outcome even after giving multiple bevacizumab injection. The mean follow-up was for about 20 plus minus 3 months. Hyperreflective walls were noted in 25, almost 22.7 of 110 foveal cystoid spaces that were evaluated. Foveal cystic spaces with hyperreflective wall had poor visual acuity. Disruption of the EZ zone and the disorganization of the retinal inner layer were more in eyes with patients having hyperreflective wall in the foveal cystic zone.
After giving repeated bevacizumab injection, in 50 cases, cystic spaces gradually decreased in 20 eyes, whereas eyes with hyperreflective wall in the foveal cystoid spaces persisted as much as 12 to 18 months visit. Among 15 patients with hyperreflective wall at baseline, 15, almost 100%, and 9, 60% had cystic abnormalities at 12 and 18 months respectively. In 35 eyes without pre-treatment, hyperreflective wall and cystic abnormalities were seen in 24 patients and 11 patients at 12 and 18 months respectively. Outcome also depended upon the baseline visual acuity, the adequate blood sugar control, and the severity of DME before initiating the anti-VEGF therapy. This is the table showing the hyperreflective wall in the foveal cystic spaces. Now, this is an SD-OCT picture that was used for assessing the hyperreflective wall in the foveal cystic spaces. The second picture shows after the 18 months after giving the treatment. Now, discussion. Cystic abnormalities without hyperreflective wall improved under anti-VEGF treatment, but poor visual acuity and more severe ellipsoid zones disruption were noted in eyes with those patients having hyperreflective walls. Hyperreflective foci may correspond to lipid-laden macrophages, but possibly promotes collagen synthesis, fibrotic scar formation of cystic spaces. Anti-VEGF therapy probably helped in disease decreasing the excessive vascular permeability, and the current study design hyperreflective wall in foveal cystoid spaces acts as a novel predictor of unremitted DME. Anti-VEGF therapy still is the first-line treatment of DME, inducing remission in very important factor. Most eyes with hyperreflective wall in foveal did not reach remission until 18 months. Visual acuity was not solely related with the hyperreflective wall in DME in cases with VME retraction. Limitations are to our study is due to small sample size. In conclude, hyperreflective wall in the foveal cystic spaces can act as a novel OCT finding and therefore has a significant clinical relevance in DME, and it has been designated, it can be designated as a predictor of refractory DME when giving anti-VEGF injections. Thank you, sir.
Thank you. Nice presentation. Just a quick question. This has been already documented earlier in literature.
Yes.
Do you think anything you have added to the study, what have been documented?
It was a similar studies.
Yeah. Anything from the panel? Okay. Thank you so much.
Thank you,
No
sir.
problem. In interest of time, we move on to a keynote talk by a dear friend, Dr. Puran Chandra. Due apologies to the speakers of the next session because of first day of the conference we started little late and couple of the speakers were unable to come on time. Just last talk of this session, Dr. Puran Chandra, over to you, please.
Thank you, sir. So this was the paper which I presented last year. It's on comprehensive approach and exploring therapeutic potential in retinal dystrophies. So as we all know, like field of genetics is evolving at a very high pace. It's surprising to know that eye is the second only to the brain as an individual organ in its frequency of involvement in genetic disorders. And almost 50% of pediatric diseases will have some genetic etiology. And clinical pictures sometimes could be overlapping and may not be enough because it may range from a very subtle clinical changes in stationary night blindness to a very severe early onset degeneration in cases of LCA. So these are the symptoms with which the patient present: night vision problem, normal central vision, but tunnel vision, central scotoma, photophobia. Some parents bring their children stating that they're not doing well in the school, and some are concerned, I have this condition, that's fine, will this condition pass on to my next generation? So what we do, as of now, we counsel them, offer them low vision aid services, we provide photochromatic glasses for the photophobia, and we monitor the disease. So due to its rarity, the clinical modules of dystrophy has not been studied extensively in India and needs to be comprehensively analyzed along with the disease phenotypes. It was an observational study approved by institutional review board and informed consent were taken. So we studied a total 45 patients in the age group of 5 to 31 years, and there were 31 males and 14 females. So all patients underwent a comprehensive eye evaluation, including imaging, and electrophysiological tests were done with strict adherence to ISCV guidelines wherever it was required. So coming to the genetic testing method, we use something called next generation targeted sequencing using a 212 retina specific genes, and a variant calling in the genes of interest was looked into. So we got 45 different mutations in these 45 patients. Among these, 9 mutations were unreported, and these nucleotide changes were not present in the 100 normals which were analyzed, and 36 variants were previously associated with retinal dystrophy. So we had 9 novel mutations with the existing spectrum of genes identified in Indian patients. So it provides further information on the genotype-phenotype correlation for the retinal dystrophy. So what does all this means to a patient, the imaging, genetics? I would like to highlight the same by giving these two case example. These two patients, both of them presented with blurred vision, fundus looked normal clinically. Whereas the first patient had a very subtle changes in the foveola and the autofluorescence, whereas OCT showed subfoveal cavitation. So when we did an ERG, dark adapted responses are completely normal, but if you look at the light adapted responses, it was unrecordable. So the defect is so small, the cones in this entire retina are non-functional. So second patient had obvious atrophic foveal changes in autofluorescence, and same was confirmed in OCT, which showed foveal thinning with outer retinal loss. But look at this patient's here, it's almost like near normal. So why there is so much of functional difference between the two clinically normal looking fundus? The reason being the first case is a case of achromatopsia caused by a mutation in GUCY2D gene, which is a stationary disorder. The patient is born like that and is going to live like that. We need to counsel and plan his career accordingly. The second case, though it looks functionally normal now, it's a Stargardt's in its earliest stage, and this patient had a mutation in ABCA4 gene, and this is likely to progress, and we can take some measures like avoiding vitamin A supplementation, protecting them against light to prevent progression to an extent. So what are the future direction? Of course, obviously we need to do gene therapy for all these patients, which basically involves injection of adeno-associated virus vectors to correct the defective gene. So this is the complex process which involves the preparation of this gene therapy product. I won't go into the detail. Basically, there are 3 steps: transfection of the 3 plasmid lines into HKE cell lines, and these are harvested 65 hours later, and they will undergo purification by affinity chromatography and ultracentrifugation, finally resulting in AAV vectors. So these AAV vectors we injected in mouse subretinally. So we used beta-galactosidase enzyme, the gene which codes for this enzyme. And this is the injection site in the mouse, and we also use green fluorescent tracking system to whether the vectors are in subretinal and how is the uptake. The uptake was good, and these eyes were harvested 2 months later. If you look at the negative control, there is an excellent uptake and beta-galactosidase activity which was seen in the mouse which received this gene, viral vectors. So we have a dedicated gene therapy production platform with an expanding team of scientists. So we also built a class 100 clean room facility. So class 100 clean room facility basically means that the sterility of these OTs are 10 times more sterile than the regular OTs what we use for retinal surgeries and the cataract surgeries. So this is first in India. And the national gene therapy guidelines are also out, and whoever is interested in knowing the guidelines and gene therapy, this is available in the ICMR website. You can just go and download the PDF. So I always conclude any of studies under these 3 headings. What we already knew was diagnosis of retinal dystrophy almost end of road to the patient. What this study adds is there's more database, and Indian database for mutation. We detected 9 novel mutation out of 45. That indicates the Indian database for mutation may be different. We can't just follow the whatever that is reported in the West. And there are subtle changes which can make a big difference in how we counsel the patient and manage the patient, and the rodent model was also studied. Of course, the future direction will be to start first in India humanized gene therapy. Thank you so much.
Thank you, Puran, and because it's a keynote lecture, we cannot ask you any questions. On a lighter note, thank you so very much, and eagerly looking forward for your future work as well. Very inspiring always. I always tell you, this is one area where not many people are venturing, and we need to look into it, and gene therapy is going to be the future.
Yes, and thank you very much for simplifying it a little more so that the ophthalmologist can understand it better compared to your previous one.
Yeah, because that time I had time constraint, no sir. Today I can around. So I was hurrying. So I was more relaxed. No.
And sincere apologies for delaying the next session. We were the opening batsman and got delayed because of a couple of speakers who didn't turn up on time. Thank you so very much.